Ladies and gentlemen, we are just in time to start our session together with Marta Guermes from Portugal and Antonio Agnelli from France, or Italy, France, and myself, Rudolf Weiner from Germany. Everybody has 7 minutes from the speaker, 7 minutes talk and 2 minutes discussion. So this needs discipline, some voice background. So we will start with the first speaker. Antonio, you will invite him.
Yes, I'd like to invite Stans van Gelder. Stans. And will give a talk on the development of bariatric population-specific body Q normative references ranges for 6 health-related quality of life scales.
Yes. I'd like to get started immediately. Good afternoon, my name is Stans van Gelder. I'm a PhD candidate at the Obesity Center Amsterdam, and today I will present the results of our study, development of bariatric population-specific body Q normative reference values for 6 health-related quality of life skills. I have no conflicts of interest. Starting with some background information, metabolic and bariatric surgery leads to weight loss and remission of associated medical problems, which I hope we all know. However, patient-reported outcomes are essential to capture the patient's perspective beyond weight loss and associated medical problems. The body Q is one way, it's one prompt to use to measure health-related quality of life, and it has skills that are relevant to patients undergoing MBS. There are body Q norms of a general population. However, they don't define the expected postoperative values for bariatric patients. And without these references for bariatric patients, it's difficult to classify outcomes as expected or suboptimal. So what is considered a normal score for bariatric patients, and how can we identify these patients who deviate from the expected course and need timely intervention? So, for example, we have a patient, he's 5 years after MBS. He has a body image score of 50 on a scale of 0 to 100. Do we consider this high or low? Well, it depends. So, for instance, for body image, a score of 50 is actually within the expected range. And it's even above the general population norms, which is 46.6. So this is not even average, but this is to be expected. So after 5 years, a score of 50 for body image would be expected. However, if you change the date, so after 1 year, a score of 50 will be below expected. And in this case, the number doesn't change, but the meaning does. So interpretation depends on the context and not the absolute value. So therefore, the aim of this study was to establish 5-year bariatric specific normative percentile values for 6 body Q health-related quality of life skills in patients undergoing MBS. We conducted a prospective multi-center cohort study in which we had included 391 patients who had underwent primary Roux-en-Y gastric bypass or sleeve gastrectomy between 2017 and 2019. For health-related quality of life, we measured for 6 skills, which were body image, physical function, physical symptoms, psychological, social, and sexual well-being. We measured this preoperative and after 4 months and 1 to 5 years postoperative. Scores range from 0 to 100, with higher scores indicating a better outcome. And the normative values we measured for the percentiles of 10, 25, 50, 75, and 90. If we look at the baseline characteristics of our cohort, we had a mean age of 45 with a mean BMI of 42.8. Most patients were female in our cohort study, and most patients had underwent Roux-en-Y gastric bypass. So the most common associated medical problems were obstructive sleep apnea, GERD or reflux, hypertension, psychiatric background, a little bit less. If we look at the results of the study, these are the percentile-based reference values for the 6 health-related quality of life skills that we measured. We see the 50th percentile, which is also the median, 25 to 50, and 10 to 25, and then below 10. We also stratified the data for several factors. First of all, for the type of surgery, we saw similar trends for patients who underwent Rougon gastric bypass and a sleeve gastrectomy. Men had an overall better score than women. Younger age was associated with higher psychological and social well-being. Older age was then associated with a better body image and sexual well-being. And the lower preoperative BMI was associated with a higher health-related quality of life overall. So this was the first step toward BodyQ, health-related quality of life reference values for bariatric patients. It complements the general population norms by accounting for low baseline scores and dynamic postoperative changes. The percentiles make it easier for interpreting individual scores during follow-up. However, there were a couple of limitations which must be acknowledged. First of all, there was attrition at later follow-up. It was conducted at 2 Dutch centers. There were only 6 health-related quality of life skills included, and the percentile should support, not replace the individualized clinical judgments. So in conclusion, we established the reference values for 6 health-related quality of life skills up to 5 years after MBS. We stratified it by surgery type, gender, age, BMI, which supports a more tailored interpretation. The low percentile scores can flag patients for timely follow-up or intervention. And my take-home message would be, it's not about the absolute score, but the context that defines its meaning. Thank you for your attention.
Thank you for being time. Very, very nice. Any questions? We have 2 minutes time for discussion.
Can I make a question? Thank you. Thank you for your work. I love your abstract. Since your study is from only 2 centers and mostly include women, do you think that these results really represent the wider bariatric population? And did these patients were submitted to plastic surgery? Do you know?
To start with the first question, what we see in a general bariatric population, I think both in the Netherlands and anywhere else, is that more patients are female than male. So I do think when it comes to gender, it does represent a wider population. And for the second, regarding the plastic surgery, we did not include it in this study cohort.
But do you think that could be an important issue for the quality of life evaluation?
According to some literature that I've read before, it does. However, the significance does depend on several factors. We do know that very few patients in our cohort did underwent plastic surgery later during follow-up. However, we did not specifically look into the outcomes for these patients, as the number of the patients were very small.
Thank you.
Thank you very much.
So the next speaker will be David Marino with the paper Early Postoperative Results of a Randomized Clinical Trial comparing 3 hypoabsorptive surgical techniques for the treatment of type 4 obesity.
So good afternoon to everyone. I'm David Marino from Barcelona at Bellvitge University Hospital, and I'm going to present the early postoperative results of a randomized clinical trial comparing 3 hypoabsorptive techniques for grade 4 obesity, that is the BAR3 trial. So first of all, nothing to disclose, and to set a bit of a context for this study, and just as a reminder that the duodenal switch is the best option for patients with BMI over 50 and associated metabolic disease, as it offers the highest long-term efficacy for weight loss and the best metabolic comorbidity remission rates. But however, it comes with technical complexity, as it requires 2 anastomosis, which leads to long operative time, and that has driven the development of simplified techniques such as SADS, which was first described in 2007, and that streamlines the duodenal switch into a single duodenoid anastomosis with a 300 centimeters common limb, and also the OGVP, which also has one anastomosis but in an omega configuration. Looking at the evidence, there was an evidence gap. There are no retrospective randomized clinical trials that have directly compared these three techniques in grade 4 obesity. So all the existing data we had came from retrospective, non-randomized, or single procedure series that makes the comparison unreliable. So that is the gap that this study intended to fill. So it is an open label, a single center randomized clinical trial with a block balance randomization that was conducted at a hospital between April 2021 and November 2023. Those patients had a BMI of 50 to 60 with an initial enrollment of 186 patients. From those patients, 11 were excluded due to the withdrawal of the informed consent or the performance of an sleep gastrectomy alone, leaving a final sample of 175 patients with 57 patients in the DS group, 59 in the SADS group, and 59 in the OHBP group. The primary endpoint of the study was the percentage of excess weight loss at 5 years. Those results, we don't have it yet, but we'll present them once we have them. And today I'm going to talk about the safety outcomes and the textbook outcome post-hoc analysis that we did. So what is textbook outcome? It is a multidimensional composite measure that integrates multiple early postoperative quality indicators into a single ordinal score from 0 to 5, and it is said to be more sensitive than isolated complication or mortality rates. The score is TBO0 is the flawless postoperative course where the patient stay under 2 days with no complication and no readmissions. Then it's the TBO1, which is a prolonged stay, TBO2 for mild complications, TBO3 for hospital readmission, TBO4 for severe complications, and TBO4 for 30 or 90-day mortality. So after the randomization, we obtained 3 groups that are comparable. As you can see, there are no statistically significant differences between the baseline characteristics, being 2/3 of these patients female with a mean age of 49 years and a BMI at recruitment of 53-54, and the percentage of diabetes, hypertension, dyslipidemia, and obstructive sleep apnea were similar in all the 3 groups. Regarding operative data and complications, DS presented the longest operative time with a mean time of 153 minutes compared to the 115 minutes of the SADS and the 98 minutes of the OHGBP. So we can say that DS had a longer operative time, significantly longer than SADS and OHGBP, with a p-value of under 0.05. And regarding complications, there was an overall complication rate of 5.3 in the DS group, 8.5 in the SADS group, and 3.4 in the OHGBP group, being severe, 1.8 in the DS, 6.8 in the SADS, and 1.7 in the OHGBP. These 2 variables had no statistically significant difference between the groups. There was an anastomotic leak in the DS and the SADS group, and 2 surgical interventions in the SADS, and 1 in the OHGBP. The mortality rate at 90 days was 0% in all 3 groups. Then there's the main finding for this talk, which is the post-hoc analysis of the textbook outcome, especially the achievement of the TBO0, the flawless postoperative course. There was a 63.2% of the patients in the DS group versus the 86.4 and 84.7 in the other 2 groups. That is a statistically significant difference. And when we analyze the causes of what was this percentage lower, we see that the DS group had a higher percentage of patients with a TBO1. That means patients staying more than 2 days. This is at 31.6% versus the 8.5 in the other 2 groups, also statistically significant. This might reflect the greater technical complexity or higher resource consumption of the DS in the immediate postoperative period. And to finish a bit of the results on the short-term weight loss at 90 days, the patients on the DS group had a mean VMI of 40.5, same as SADS group, and 39.6 for OHGBP group, with a percentage of total weight loss of 16, more or less 16 across all 3 groups, and a percentage of excess weight loss of 33, 32, and 35%, respectively, with no statistically significant differences between the groups. And just for the conclusions, we can say that with these early results, primary hyperabsorptive and these 3 techniques is safe in patients with grade 4 obesity with 0% of mortality and a low rate of CV complications. That DS requires more operative time and higher resource consumption. Also, the achievement of TBO0, the flawless operative course, is significantly lower after duodenal switch. And at the short-term weight loss, the 3 techniques perform in an equivalent way, but of course the long-term data will be the key to whether to determine if there is one technique which has a higher efficacy than the other ones. That would be all. Thank you for listening.
Any question from the floor? I have one. I mean, if I understand well, these are the initial results of a randomized trial. But how is powered your study for the primary outcomes?
Sorry?
What is the power of your study? How you powered your study for the primary outcome? Which difference you want to see between groups?
It's a 3-arm trial, so we did an ANOVA 3 sample measuring with the theoretical excess weight loss percentage of each technique, being 85 for the DS, 80 for the SADS, and 75 for the OHVP, which lead to a standardized deviation of 20%. That would be the value you asked for, and with an alpha raise of 0.05 and a beta raise of 0.2. That leads the 186 sample size.
We are waiting for the 5 years results. Thank you.
Yes. Okay. But is there any other question? No question. Thank you so much. So now we are calling Dr. Yafit Kessler. We'll talk about a comprehensive multidisciplinary remote intervention program for recurrent weight gain after sleeve gastrectomy. Another randomized trial. Good.
Thank you very much. I have nothing to disclose. I hope I can talk fast enough. So today I will present one of 2 RCTs we conducted on my PhD. And it's a comprehensive multidisciplinary remote intervention program we developed for weight regain sleeve gastrectomy, after sleeve gastrectomy. So weight regain does not have a standard definition in literature, so the rates vary widely, but we do know that it's a growing problem and it demands special attention. We know that it is associated with maladaptive eating behaviors and insufficient follow-up, and there is no consensus regarding effective interventions for metabolic bariatric surgery patients with weight regain. So our aim was to assess the effect of a 3-month remote multidisciplinary intervention program on physical and behavioral outcomes among sleeve gastrectomy patients with weight regain. So we included adult patients in our research, where they were at least 2 years after surgery and with at least 10% weight regain from nadir weight. And we recruited 100 patients and randomized them into intervention or control group. We measured baseline and post-intervention data and then did follow-up 3 and 6 months after the intervention ended. So this is our intervention. The group received, all in all, 12 online virtual sessions, 6 with a dietitian, 3 with a physical activity consultant, and 3 with a sleep consultant. And they also received weekly text messages targeted to promote their well-being, all in all 12 messages. The control group received standard care, which is 1 session with a registered dietitian, with a recommendation to follow up with what we talked about in the session and to engage in physical activity. So the data we collected at baseline in 3 months was body composition and weight within body. We did measurements of waist circumference. We measured functionality with hand grip and sit and stand test. We took dietary intake and also questionnaires on eating behaviors and lifestyle. And then 3 and 6 months after the intervention ended, we measured body weight and gave them the questionnaires. So the eating behaviors questionnaire we used conducted 8 sentences, which are the post-operative eating recommendations, and each patient had to answer if they never do them, partially do them, or always do them. We took a 3-day food diary log. We asked them about grazing behavior and about binge eating behaviors, and also about sleep, sport, and multivitamin intake. So the baseline characteristic you can see in front of you, the majority again was women. The range of time after surgery was between 2 to 16 years with a mean of almost 8 years after surgery. Most of the patients had a good success after surgery with above 90% excess weight loss, but at recruitment time it was 54% excess weight loss. So they had a median weight regain of 15 kilos and 22%. The main goal was weight trajectory, so weight remained stable along the study for both groups with no significant difference between them, but we did see a trend towards better weight loss, weight maintenance or weight loss among the intervention versus the control, both at the end of the intervention and even 6 months after we finished the intervention. Functionality score significantly improved for both upper and lower extremities in both groups, and the intervention showed greater improvement in lower extremities strength. We saw that both groups improved almost all their behaviors, with higher improvement among the intervention for choosing solids and combining protein in every meal. You can see this on the graphs. The blue graphs are the intervention, the gray is the control, so they improved almost all the behaviors. And the reported dietary intake showed us some interesting observations. We saw that the majority, a bit over 50%, reached the minimal protein target, which is 60 grams per day, but only almost 15% reached the optimal protein intake, which is 1.5 gram to ideal body weight. Both groups improved their daily water intake with a better improvement among the intervention group. And within group reduction for all behaviors was seen only among the intervention group when looking at maladaptive eating behaviors. And higher reduction was observed among the intervention for, for grazing behavior. And if you look at the numbers, the grazing went down from 70% to 30% in the intervention group compared to 64 to 62 in the control group. So it was very meaningful. Regarding lifestyle habits, sleep had no impact in our intervention, and a significant improvement in multivitamin intake was seen in both groups. Lifestyle habits of physical activity changed, with the intervention group showing higher improvements in engaging physical activity, reaching the recommendation of at least 2 anaerobic sessions a week, and improving the absolute aerobic minutes per week, but they did not reach the recommendation of at least 150 minutes per week. And another interesting observation, we saw that more patients among the control group initiated obesity medication treatment during the study and also after the study compared to the intervention group. So to conclude, the intervention demonstrated superiority in several parameters, enhancing physical activity, improving lower extremity strength, adhering to multiple eating and lifestyle behaviors, and reducing maladaptive eating behaviors. But weight loss was minimal, although the intervention group showed better weight maintenance trends. And the future implications are to develop a remote, multidisciplinary, patient-oriented program to promote patient engagement by offering accessibility and promote patient outcomes. Our baseline characteristics were published in a research in the surgery of obesity and related disease, so you're welcome to read them. And I would also like to say in the results part, as was said in the stigma presentation at the beginning of the day, that success is not only the weight on the scale, it is health, it is quality of life and functionality. I would like to thank my amazing team, and most of all my supervisor, Dr. Shir Shef-Dagan. Thank you.
Thank you. Any question from the audience? So I have 2 questions. How you justify to stop the intervention at 3 months of follow-up? Why 3 months? And the second question is how you measure the physical activity for those patients? It was with a diary also?
So the first question, we chose 3 months intervention because it's enough time to show a weight change. Because we recruited 100 patients, not in one day, so we needed the time to start and a time to end. I think an intervention is for life.
Sorry, but 3 months, it's enough to change habits? Do you think so?
No, I do not think 3 months is enough to change habits, and I think that's the difference between academic and real life and real clinic work. I agree. Ideally, I think patients should be in follow-up from the surgery, and weight regain should be prevented and not treated. But I think 3 months was what was able in concluding all the data we have and all financial considerations we had. And the second question?
How you measure the physical activity?
So we asked patients, they reported their physical activity. We did not use meds or any validated questionnaires. We asked them if they do physical activity, how many times a week, and which kind of physical activity.
Thank you.
There's another question on the floor.
I don't think it's working, but are you going to change anything in your clinic based on the results of this study?
It's an interesting question. I think, as I've said, that weight regain intervention is less effective when you take patients that have a high weight regain, 20% weight regain. There's a limit to what we can do as clinicians. So I think our job is to engage our patients, reach out to them 1-2 years after surgery, the time we know they start weight regain, and to help them prevent it with a multidisciplinary team. And sometimes patients with more weight regain, more than 10%, maybe they need stronger interference like medicine or bariatric surgery or endoscopic.
But will you also offer an intervention like this to people who have weight regain 2 years after surgery as a standard care, or?
Yes, I think so, and I would also engage another arm of healthcare with a psychologist.
Okay, thank you.
Thank you very much.
Thank you very much. And now I'd like, to invite Professor Andrea Lazzati. Sorry, Andrea. Forecasting national metabolic bariatric surgery activity using statistical and deep learning models.
Good afternoon. Thank you for this kind invitation. In the next few minutes, I would like to deal with a question that maybe you ask yourself sometimes is how many procedures we are going to do this year and how many procedures we are going to do next year. So in order to answer this question, we took a 13 years national database data and we applied several algorithms to try to respond to this question with solid data. The problem is that bariatric surgery activity is not stable. It depends on seasonal and yearly trend and is always sensitive to some unexpected events like the COVID pandemic. But planning the organization of a surgical department needs stability. So our question was, how can we forecast the national bariatric volume accurately enough to provide information for planification? So we split the question in two. The first one was finding the best statistical model between three that we used, a classical statistical one, a second interpretable additive, and a third deep learning model. And the second part is the chosen algorithm, the chosen model will be accurate enough to have a prediction strongly enough with a small error. So this is the data we started from. It's the national activity in France from September 2012 until December 2024. So it's almost 13 years of activity. And in this graph, we can see already three patterns. The first one is that every month of August, you can see a very deep decrease because French surgeons go to holiday every August. So we don't work so much in August. And it's regular. Every year we have this pattern. And similar patterns are all seen in other months. The second pattern is the progressive increase until a period between 2016 and 17, and then a progressive decrease. Obviously, the third pattern is the COVID pandemic in 2020, which represented a very strong decrease in bariatric surgery activity. These are the three models that we use. The first one is SARIMA, called SARIMA, which is a very classical statistical forecasting model with it's a regression model, quite classic, using a moving average. Okay, it's very efficient when the events are quite stable. The second one is called PROPHET and is more an interpretable additive forecasting model using several layers, and so taking in account the calendar variation by information. This is the model that Facebook uses for forecasting business time series. And the third one is a neural network model, a deep learning model, temporal fusion transformer, TFT, which is probably labeled as the most efficient nowadays, but it needs a lot of information. So we took the period between 2012 until 2023 as a training set, and this is 458,000 procedure. We took the year 2024 as a validation set, 31,700 procedure, and then we forecasted the year 2025. We took in consideration, in account, the public national holidays, because French really likes to go on holiday even during the year, not only in August. So there are 11 public holidays, and you can see that every public holiday is associated with a very strong decrease of the surgical activity. And so this is the behavior of the three models compared to the real activity. The black line is what really happened in 2024. And you can see the three models. The yellow line is the classical model with a mean average. So it's not very sensitive to the big changes. While the two other models, the PROPHET, the Facebook model, we can say, and the deep learning model are much more closer to the real events. At the end, the forecast in the training set, we had 1% of error with the PROPHET model, the Facebook model, and the deep learning model was the second one with only almost 2% of error on the whole of the annual prediction, while the classical statistical model has a bigger error. So this we decided that PROPHET was the elected one, the selected one, and we applied and we tried to predict the 2025 activity. And 3 weeks ago, so we predicted them, and 3 weeks ago we had the final data. And this is the prediction. We predicted 30,000 procedure and 500 procedure, and the real data is 30,200 procedures. So we have actually, in fact, a 1% of error. So we are very glad because it confirms the validation set. And now we are forecasting, obviously, for the next year. We don't still have the data for the ongoing year. Our model suggests that for this ongoing year, the progressive decrease of bariatric surgery will probably stop, and probably will have a slight increase again, with a margin of error, obviously, which is considered in our analysis. Obviously, there are some limitation of this. This is a national forecasting. It's not a regional level or a hospital level. This will be our second step of our research, try to have an algorithm that can be applied at an hospital level. The second point is that we are a little bit disappointed by the deep learning model, but we had only even if we have 500,000 interventions, it's not enough for a deep learning model, so probably we will have to wait a few years to have a better performance with this model. And obviously, this kind of model cannot forecast some disrupting event. We had the COVID pandemic, but the most likely disrupting event in the next year will be the reimbursement of anti-obesity drugs that could really affect the number of procedures. So we will see what it happens. So in conclusion, between the three forecasting models, the best that we found was the Profit, the additive model from Profit, while the deep learning was just the second, and the prediction of 2025 was very, very close to the real data, and we just have a 1.2% of error. Thank you very much.
Great. Great, Andrea. Is there any question from the floor? There is one. Daniel Gero.
Probably because at the end, during the year 2025, there is a trend of re-increase because the model takes in account day-by-day data, not only in general. So probably there is a shift that's going on in 2025 that when we observe the whole year, we don't see it. But when we look week by week and month by month, the model found that probably at the end of the year 2025, something moved toward the top. This is the explanation I can give you.
Andrea, I'm curious about that. You said that you could forecast the number of procedure, but you cannot. I mean, the COVID is a black swan. I mean, this is something no one could predict. But medication use, evolution of surgery. Bariatric surgery, because of the introduction of medication, should be forecast because you have several elements. I mean, new drugs coming on the market, number of drugs that per person, and duration of medication. So I was a bit surprised. I think you can do better going into the SNIRAM base and look for the use of drugs. Will you do that?
Well, yes, we can do that, but medication have been there for 2 years, and we didn't see any disruptive effect. There's no great reduction since the medications have been introduced. And the recent data suggests there are 2 to 3 times more people taking medication than having bariatric surgery in France. And despite this information, bariatric surgery did not decrease significantly. So until now, without reimbursement, the effect of medication seems to be marginal.
Okay, if there is no other question, we thank Professor Lazzati. Please introduce the next.
So the next speaker, Albert Bouza from Spain. Metabolic surgery program for patients with spinal cord injury, eligibility, feasibility, and safety.
So good afternoon, everybody. So my talk is about metabolic surgery in patients with neurogenic obesity and spinal cord injury. Nothing to disclose. So this is Hospital German Stiers, the big building, and this white building under the hospital is Institute Guttmann. It's a national reference center in neurorehabilitation. So I start the talk with a question: what do you do if you have a patient with a spinal cord injury and obesity in your clinic? So I asked this question in the Twitter. So different questions. So Norberto Casinello from Valencia, not to operate them. In these unfortunate patients, bariatric surgery is not the answer. My colleague, Dr. Tarasco, bariatric surgery can help the comorbidities, can help this quality of life, their autonomy. Dr. Carlos Ferrini from Madrid, good question. There are some results with gastric bypass, but maybe sleeve is a good initial procedure. my boss, Dr. Balibrea, the evidence is scarce, but sarcopenia and the exercise restriction are the key issues, and not evidence, but there's some cases, bypass and sleep, but not really evidence. So this is the first paper to talk about this concept, neurogenic obesity. They have adipose tissue changes, sarcopenia in the inferior trunk, this neurogenic osteoporosis, neurogenic anabolic deficiency, sympathetic dysfunction, alter their energy balance, and different body composition. So this is the first time that they talk about this neurogenic obesity. So how can we measure this obesity in these patients with BMI, with spinal cord injury specific BMI? They are easy to classify, but not sensitive with physiological changes in these patients. So we have to use the gold standard is biometrical impedantiometry or DEXA with total body composition are the gold standard. So they define this neurogenic obesity with a spinal cord injury specific BMI more than 22, % of fat more than 22 for men, and more than 35 for women. So we start a new program offering surgery in these patients, patients with obesity and spinal cord injury. And what did you do? We have this retrospective cohort, 530 patients in this neurorehabilitation hospital, and we classify the patients with this BMI more than 22 or less than 22. We have 111 patients less than 22 and 419 patients with BMI more than 22. These are the demographics of these patients. And this is the presence of obesity-related diseases in these patients. So we can see that patients with BMI more than 22, they have more hypertension, more diabetes, more dyslipidemia, and statistic significance. So we start our program offering metabolic robotic surgery 2022 until now. And this is the scheme of treatment. The patients are evaluated for a multidisciplinary team with anesthesiology specialized in spinal cord injury, rehabilitating doctor and rheumatologist. We perform a gastroscopy, abdominal ultrasounds plus elastography, GI series, bioelectrical impedantiometry, hand grip, and DEXA with total body composition, and we repeat 6 months, 12, and 24 months. This is the inclusion criteria: spinal cord injury more than 1 year, BMI more than 30% of fat, more than 25 men and more than 35 in women. Complete tetraplegia, ASIA-A are excluded, oncologic etiology of spinal cord injury excluded, and normal exclusion criteria. So this is the flow chart of this retrospective cohort. We have with BMI more than 30, 200 patients, evaluated 76, and eligible for metabolic surgery, 12 of them. We performed 7 sleeve and 5 Roux-en-Y. And one of the keys of this communication is this not eligible for metabolic surgery, 64 patients, because they have a lot of eating disorders, psychiatric disorders, substance abuse, good response to dietetic treatment, also patient decisions, so this is difficult. And these are the demographics of these 12 patients that we perform surgery: 9 males, 3 females. We have BMI 40, body fat 57. The etiology, majority of them are traumatic with previous laparotomies, splenectomies, so very difficult patients, and 1 spondylitis ankylosant. So these are the results. The operating time is higher than usual, 90 minutes for sleeve gastrectomy and 221 for the Roux-en-Y. Also, the docking time is higher because of these previous laparotomies. We perform partial dockings, and so it's a little bit higher. The hospital stay was 3 days in our hospital and 5.5 days in Institute Goodman to perform the rehabilitation, posterior rehabilitation. Complications: 1 hemoperitoneum who was reoperated, and 1 perianal abscess, and 2 pressure ulcers. to reintervention and 0 readmissions. And this is one of the patients with ankylosing spondylitis, so also difficult for the anesthesiologist. So this is results of 6 months follow-up with total weight loss, also percent of fat, and we see also decreasing in skeletal muscle mass. So we have to be careful with this sarcopenia in these patients. And these are the results in 2 years, good results, but also be careful with this sarcopenia. Results in percent of fat, good results in 1 year follow-up. And this is we saw that the skeletal muscle mass is decreasing, but not the strength. They have more strength at 6 months follow-up. This is the results in terms of blood test, good results in glucose and parameters of lipidemia. So the conclusion is it's safe in short term to offer metabolic surgery with proper selection of the patients, low eligibility due to increase the incidence of psychiatric disorders, major depression, eating disorders, lifestyle, drugs abuse, and patient decision. The robot can increase the safety in these complex patients. Sarcopenia is a red flag. Well-monitored total body composition, good alimentary supplementation, and upper trunk rehabilitation could be the solution. Be careful with complications like the cubitus ulcer or perianal abscess. The correct mobilization, air mattress, and avoid constipation are the solution. And they can improve the metabolic comorbidities, quality of life, and autonomy, and we show more evidence. So thank you.
Any question from the audience? So it's difficult to talk in safety with 12 patients,
Yeah.
I understand. But how do you explain this low percentage of patients that want to do the surgery? Why is it so difficult to convince those patients to?
Well, we tried to convince them, but we saw that the patients, maybe one of the pleasures that they have is to eat. So maybe if you do just one intervention of dietetic treatment, they can lose weight, and they are okay with that. So we offer also we also offering drugs in, I think, 10 patients. But offering surgery when you explain to them that they can't eat like before, so they don't want to lose this pleasure.
So you are convinced with this surgical treatment for those patients?
Yeah. We do in the clinic. We are in the same day. We are with the endocrinologist, dietist, me, and the rehabilitation doctor. So it's a multidisciplinary clinic. In the same day, the patient has all the opinions. So.
Okay. Thank you.
Thank you.
Thank you.
Now we'll move to the next presentation by Dr. Sabateia, who will talk about the comparative efficacy of metabolic bariatric surgery versus GLP-1 receptor agonists. And this is a network meta-analysis of randomized trials. Please.
Yeah. Oh. Okay. Good afternoon. Thank you very much for the invitation. Let's talk about the comparison of both approaches for obesity in a context of randomized controlled trials. Well, the overview is a little bit of background, the epidemic of obesity and the emerging of GLP-1 receptor agonists. We perform a network meta-analysis of 30 randomized controlled trials. We divide the results in short terms, less than 140 weeks, and long term. And then we evaluate, just describe the safety profile, and finally, the conclusions. Well, a little bit of background, how we can compare both approaches if there is not a randomized controlled trial comparing it. So due to this not head-to-head randomized controlled trial, we perform a network meta-analysis with lifestyle intervention as common comparator to give inference, robust inference. So we perform a systematic review with all the possible mesh terms comparing GLP-1s versus lifestyle intervention and surgery and lifestyle intervention with all the Boolean terms possible to compare all of these mesh terms. So the first search gives us 18,000 articles. We screen them till the last 30 articles included. These articles englobe 20,000 patients, 18 trials of GLP-1s, and 12 of metabolic bariatric surgery. We used a framework, a frequentist framework with random effects to be more robust. All these databases were searched, and the primary outcomes were total weight loss, a reduction in BMI, loss of weight in kilograms, and a reduction in waist circumference. Obviously, we look for comorbidities, diabetes and systolic blood pressure, and we certify the results on the follow-up. So these are the articles. In the left side, we have the GLP-1s, and the right side, the surgery articles. All of them are the best possible evidence, and as we can see in the Cochrane RAPT 2.0 tool. So it's a network of evidence. These are all the nodes. We use the lifestyle intervention as common comparator, and we include semaglutide maximum doses, tirzepatide 5, 10, and 15 doses, and liraglutide 3 milligrams doses. And in the surgery arm, we include routine gastric bypass and sleeve. These are the forest plots comparing all types of surgeries and all types of medications. Simplified surgery is better significantly in all of the aspects. Total weight loss, more than 10% reduction comparing with drugs. BMI reduction of more than 4 points. Weight loss in kilograms, more than 11 kilograms in weight loss in comparing both approaches. And a reduction of more than 12 centimeters of waist circumference. So in the short term, less than 2 years, we have here that all the outcomes are metabolic bariatric surgery performs significantly better comparing with the drugs excepting systolic blood pressure. But it's interesting not only analyze all the surgeries and all the drugs, it's important to select, to do subgroup analysis. So we use two subgroups, mainly semaglutide maximum doses and tirzepatide maximum doses. Here where the key aspects were shown. So if we only select semaglutide, we see that it's in parallel with the main analysis, with all surgeries and all drugs, except in the HbA1c, they are diabetes drugs, so it's normal. But the interesting thing came out with the tirzepatide, where in total weight loss and in BMI reduction, there weren't difference in the short term. Of course, there's limitations because we have the Hawthorne effect in this aspect, because in the randomized control trial, the investigators are with a lot of vigilance under the patients, and this is going to improve the results. These are not the same results as we see in real life. So this is important to take into account. If we select the long term, we can see that long total weight loss and body weight, the metabolic bariatric surgery performs significantly better. In the diabetes remission sphere too, but in the waist circumference, BMI, and systolic blood pressure, there weren't difference. But it's important to say that there's not enough power because the drugs hasn't enough follow-up. We only have, in the longer follow-up, 3.96 years in the tirzepatide. So it's important to say this. There's no enough follow-up, so this could underpower all our investigations in this aspect in the long term. And the last subgroup is the diabetes, two-type diabetes patients. This is very important. We only select patients with diabetes, and we compare first all the surgeries to all the drugs, and surgery, of course, performs significantly better in all the outcomes. But if we select only tirzepatide patients and we compare with the metabolic bariatric surgery, here, yes, the tirzepatide doesn't narrow the gap, so surgery performs significantly better in patients with type 2 diabetes. So this is important to take into account. Of course, the HbA1c is not significantly different in some subgroups because they are diabetic drugs, so it's quite normal, and in this aspect, surgery is not quite wide, the gap. Finally, safety profile, we have GLP-1s, the common gastrointestinal aspects, quite frequent. And in the metabolic bariatric surgery, non-mortality reported, complications, surgery complications were infrequent. And the most common was the nutritional aspect. In the nutritional aspect, we see that in the patient who doesn't follow the nutritional recommendations, we can have 20% of this malnutrition complication. So which are the conclusions? Metabolic vasectomy surgery remains the most effective intervention for weight loss. Tirzepatide narrowed the gap, but of course with this effect on Hawthorne effect, we have to take into account because of the RCT context. MBS performs significantly better even compared with tirzepatide in type 2 diabetes. Of course, there's a distinct safety profile, and we need more investigation comparing this in the long term. And of course, the future is the personalized obesity care future with this neoadjuvant approach mixing both approaches. Which are the limitations? Of course, there's an indirect comparison because they are not head-to-head randomized control trial comparing both approaches. This is a call for this type of studies. Limited long-term, as I said before, in the pharmacological arm. High discontinuations. Of course, in the randomized control trial, we only have at most 7% of discontinuation, but in the real life, we have higher than 50% of discontinuation. This has to be taken into account. Of course, higher rate of weight regain after discontinuation, who can reach 70% as we see in the first year after cessation in the last evidence. And of course, the consistency of safety is important. This is a network meta-analysis of indirect comparison. Of course, this has to be taken into account, but there's the first step to next investigation comparing both approaches. We have been lucky to publish this article in the Obesity Society. And that's it. Thank you very much.
Thank you very much. Is there any question from this timid floor? No one is asking questions to animate the debate. So, I mean, I found it interesting. I mean, clearly it's indirect comparison, but somehow it points out that, surgery does better than medications. And he said that there are no long follow-up in drug arms, but if you look at that, it is more in favor of surgery because we all know that this drug discontinuation leads to ineluctable weight regain. So if you probably had longer follow-up, comparable follow-up in the arms or medium-term follow-up, you would compare surgery against lifestyle, and we would fall in what we have seen in the past. Surgery does better than everything else. So, somehow we'll see. But
yeah,
it looks like,
yes, a little bit of hope, but I think in this context we need a different type of approach. We can't do the classic RCTs. We need a real-life RCTs in which we can see what's happening in the real life, because in the RCTs there are a lot of follow of the recommendation, and this is not happening.
But this is clear. I mean, the era of randomized trial. I mean, there are people who believe that the truth is only randomized trial, which is extremely far away from the truth, because we will not start this. But I don't say I'm against randomized trial, but probably only a small 5% of question in medicine should be addressed with this. Probably the answer to this kind of question would come from prospective cohorts.
That's it.
The longitudinal prospective cohorts, which are costly, but give you an amount of information you cannot retrieve from any randomized trial. This is, but if you say this, then people point out that you're saying why. But the network meta-analysis or stuff like that are kind of surrogate that can anticipate what will happen in the future.
It's the first stone to the fall. Yes, that's it. It's the first part.
So excellent. Thank you very much.
Thank you very much.
And introduce the next speaker.
So the next speaker is Mirko Otto from Germany. Preoperative use of a mobile application within the multidisciplinary team approach, a randomized controlled clinical trial.
Yeah, hello all together. Thanks a lot for introducing me. I'd like to show the results of our Optima study. I think to clarify some things is there are in Germany, and I think it's in a lot of other European countries also the same, that before patients get access to bariatric surgery, they need a half-year multimodal treatment. And in this half year, we recognized that there are quite some patients we lost in that time who never get to any treatment at all. So we asked us if there's how many are them, and is there something we can do to minimize it? You know, only 2% at all get treatment, so 98 of the population not. So it makes sense perhaps to raise this number. So there are some disclosures. I'm a surgeon, so this makes things perhaps a little bit more pro-surgery. And the app we use is provided by Johnson & Johnson. We designed it new, and actually it was done for something else, but we used the same software, so I have to say that also. During 9 months and between 2023 and 2024, we screened 709 patients, which come the first time in our outpatient office. From this 709 patients, actually only 223 really have the inclusion criteria, which are the normal ones who are, they like to get surgery, and they have the indication for it. So this is actually also, they're sure if they're pregnant, and so it makes no sense. But so there are quite a lot. They are at that time already starting and trying to use first medication, so we're not getting them into this study. And then we provide them with this application app, and then we on the first visit we say, okay, what they need to do is like endoscopy, cardiology, whatever what we need before surgery, and then this app helps them to remember and give information connecting to our sites and provided easy contact. So if there are coming up some questions, they're typing the question in, and we give them standard answers to these questions. And if there's no standard answers left, there was easily contact to us. And then, okay, we have 114 in one group and 109 in the others, and we stratify by gender so that there are not too big differences in there. And we come up to around 90 again. 90 is 87, again 91 in both groups. We wasn't able to do a power calculation because there was no study and no data we can use for power calculation because there was no standard variation which we can pick. So we need to do that as a primary RCT to see what came up with. So the risk of underpower is there. These are the baseline characteristics. We have an average BMI in both groups. The control group with not having app was 47, the other one 46. So the patients with obesity grade 4, 5 wasn't suitable for this study because they wasn't able to go all the examinations. This is why it's a little bit lower than our average. In Germany, the average is about 49, going to bariatric surgery in a moment. So we have the number of females are the same because we stratify for that. What's pretty interesting is a little bit of co-founder for the results is if you see it, it's down there that we have pretty a difference in university qualification. So there's pretty high qualification in the control group and much less in the app group. This could be a confounder, which we didn't stratify before. So this is to say, and if we see, we didn't find a difference between the control group and the app group if we take all together. But what we see is that the ones who are using it, they perform better than the one are not using it. So we wasn't able to show that this the app really helps getting more people into bariatric surgery. But what you see here, but I think it's really interesting that the control group you see is 60% only come to bariatric surgery. So we lose 40% even if we understudy conditions. And in the app group, even the ones who are using it a lot, only a little bit more than 70% at the end gets the bariatric surgery. But on the other hand, if you only get 2 or 3 out of them, you already have done all the work. So perhaps, you don't need, you have done all the work. They come do all to assess it. So it makes sense to invest here, perhaps time, to get this number higher. So we come up with 115 patients who really get it in, who really get appointment for the operation, and we was around 7.8% who not need bariatric surgery due to weight loss. This is quite interesting, I think, that we had in this time of around 8% was no need in this moment. If this will stay the same and if it makes sense is another question, but due to German guidelines, we are not allowed to operate patients who lose more than 20%. This is like it is. If you see the complication, the rate of how many patients was able to do all the stuff we told them to do before, you see that the control versus the app group for nutritional counseling is much better. So even with all of them, if you use an app, you get more people into nutritional counseling. So it's 13% more, and this was statistically significant. Also with the psychological consultations, and for the other one, you wasn't able to show that with that amount of power we provide in this study. You always have significant results if you go to the ones using the app a lot. So what I would conclude of all of that is that we wasn't able to show that the app make more people go to operations, but we see that if they use the app a lot, it will work much better. So the result is that we have to care for the ones who are not using the app, because they have really high risk that they are not able to get to surgery, even if they have an indication. So in the ones who not was able to use the app, or don't like to use it, it was all able, and we tested it before, only around 15% getting surgery, even if they need all of them that. So it makes sense to care of the ones who not use the app. So this could be perhaps helpful in that setting. Thank you.
Any question from the audience, please?
I have two simple questions. Who developed the app? Because I didn't quite get it. Who developed the app?
Okay, the app. So what we have done is we used this app actually was designed for follow-up after bariatric surgery. And where we used the same app, but we put new questions and new...
So it's something that is in your current practice?
Yes.
Practice.
Yeah, yes. We designed it for this study. Yeah.
And the other question is, it is not clear, because you said that somebody used the app seldom and somebody...
Yeah.
Did you fix a cutoff?
How we do that?
Otherwise, you get a wide range of data and you don't know where to put them.
What we have done is we have done an over and under the curve, and we see where is the sensitivity and the specificity was the best, and it was 33%. So all of the one with there was the specificity and the best. So this is why we choose 33 in this regression model. And this is then we have under 33 was seldom and over 33 was the normal users.
Just one quick question. I didn't understood how you classify what it is an optimal engagement and low engagement with the app.
Okay, how we stratify that? Yeah. Okay, what we have done is we was able to see how often the app was used. So we're getting the data from the patients how often they used the app, and then we build up a curve from the result and how often they use the app. And under 33% of usage, how we expect them to use.
It's a time during the number of...
we have a fixed expectation. So we say to them, okay, we remember you to that, and then they say, okay, I have done the contritional counseling, and then they say, yes, I have done it, and then this was, we have accepted, okay, you have done that. And if they say they didn't react to this question, we say, okay, they didn't use it. Yeah.
Okay, thank you.
Yeah.
So we move to the next presentation by Dr. Mathilde Gobert, who present this is a multi-center expert study on one anastomosis gastric bypass at 10 years, safety and efficacy of 1.5 meters versus 2 meters BPD length.
Thank you. Good afternoon, everyone. So I will present our multi-center expert study about one anastomosis gastric bypass, in fact at 10 years. OAGB is an effective and simpler procedure in alternative to ONI gastric bypass. However, concerns remains about the risk of malnutrition and the optimal limb length. That's why several authors has proposed shorter the longer the length of the biliary limb, and with the 150 centimeters to avoid the complications. So the long-term data remain limited. That's why our study focus on the results at 10 years. So it is a registered observational study combining retrospective and prospective data. We built a cohort of patients who underwent OAGB across 5 expert centers. Then patients were randomly selected to create the study sample. Primary endpoint is the number of serious adverse events in each group, defined as deaths, life-threatening events, hospitalizations, major disability. Based on Omega study, we estimate the sample size at 160 patients. Secondary endpoint was weight loss, remission of comorbidity, reflux, and nutritional status. So we included 157 patients in OAGB 150 group and 161 in OAGB 200. So there is some baseline difference between the two limbs. That's why we applied propensity score adjustment to have the same group. For the result, both limb length has similar safety profiles at 10 years. Late surgical serious adverse events was frequent with 1/3 of patients, mainly driven by gallstone disease. The first causes of conversion of OAGB was the reflux, more in OAGB 200 group. Importantly, OAGB with a 150 centimeters biliary limbs don't avoid nutritional complications. There is 1 death in each group of nutritional complications after OAGB, 1 with severe malnutrition and Korsakoff syndrome, and in OAGB 200 group, liver failure in a patient with prior MASH. Both limb length achieved excellent long-term weight loss with no difference between groups. Excess BMI loss was 76% in OAGB 150 group and 71% in OAGB 200 group. More than 70% of patients maintain excess weight loss above 50% at 10 years follow-up. Regarding remission of comorbidity, there is more remission of diabetes in OAGB 200, but not statistically significant. But at the baseline, the prevalence of diabetes was also higher in this group. Remission of arterial hypertension was significant higher in OAGB 150, and approximately 80% of patients report resolution of obstructive sleep apnea. Concerning reflux, revisional surgery for reflux at 10 years was more frequent in OAGB 200, with 13% of patients versus 6.6% of patients in OAGB 150 group. This may be related to difference in reflux management between centers. At 10 years, reflux symptoms were similar between groups. 1/4 a patient reported daily reflux. Endoscopy evaluation was poorly accepted by patients. Among these assessed, esophagitis was observed in 80% of patients in OAGB 150 and 30% in OAGB 200. Regarding nutritional deficiency, during patient interview, we observed that diarrhea was more frequent shortly after gastric bypass surgery. However, the symptoms tended to resolve over time. Albumin and prealbumin levels were preserved at 10 years follow-up. Hemoglobin level was lower in OAGB 200, statistically significant, and there is more patients having received at least one iron infusion during the 10 years follow-up in OAGB 200. Patients also reported a traumatic fracture, raising concerns about the risk, the long-term risk of osteoporosis in these patients. Finally, around 20% of patients has a BMI below 25 at 10 years. That's raising concerns about the risk of sarcopenia in these patients. And we need further investigation to assess them. So OAGB is a malabsorptive procedure and use a 150 centimeter biliary limb, maintain excellent result on weight loss, but don't avoid nutritional complications. Thank you.
Thank you very much for this study that looks like well-designed, but I have only one question. I really liked it, Mathilde. It was a nice study. But how did you power the study? I mean, which was the difference you wanted to see between the two groups at the beginning?
At the beginning, the number...
The primary endpoint was...
serious adverse events.
So how you
Safety.
choose to power? Yes, but how you choose this difference based on what? On literature, on other studies, on a pilot studies, or what?
It's based on Omega study to see the difference with the data of 200.
Okay. So the study that is now ongoing in France with the shorter the shorter omega loop. No. Okay. The omega was the one that was published, but now there is another one ongoing.
No, the first.
It's shorter. So what I was saying is that if what you're saying is truth, you will have the same results in the current trial, the trial that is ongoing, that will be the same as the one that has been published, because it doesn't change anything.
We will see in 10 years.
One question from Ruth.
I have one question. How you're measuring the limb length? Free-handed 5 centimeter steps, free-handed 10 centimeter steps, or using tissue in all the procedures? You know, if you're measuring the procedures later on again,
If the size of the length is the same, it's impossible to know that because it is a retrospective study, but also in a prospective study, it's never the same between surgeons. I think there is...
5 centimeters or 10 centimeters or...
No, she said actually that she cannot say that because retrospective study. But probably, Matilde, my feeling is that probably the groups at the same length. This is why you see the same thing. Probably, this is an hypothesis, but anyway, do you know what I mean? It says half a meter is too small to have, to be able to discriminate between two different populations. For the bowel, especially in a retrospective design. This may account for the results, but thank you very much for the presentation, Mathilde. So, we have the last speaker is Daniel Gero from Switzerland, who is going to present a young IFSO study on the surgical conversion of endoscopic sleeve gastroplasty to standard bariatric procedure. Please, Daniel.
Thank you so much, Professor Iannelli. Dear audience, it's good to see some friendly faces. I will go straight to the point because I understand that the coffee break is around the corner. So I'm very happy to present the study which was performed within the framework of the Young IFSO. Some of my all of the co-authors are listed near my name. Moritz Fazenreich, Abu Abid, Adam, Sonia Chapetta, Suzanne Blank, Thibaut Coast, and Aaron Taskin. So our focus was to investigate the outcomes in terms of complication rate and weight loss after endoscopic sleeve gastroplasty converted to a standard bariatric procedure. I'm working in a bariatric reference center. This is my case mix, and we are mainly doing revisional bariatric surgery, mainly laparoscopically, and our primary cases are Roux-en-Y bypass or sleeve gastrectomy. When we look to the United States over the last couple of years, we can see that the first time in the last decades there's a decline in the overall bariatric procedure caseload, and this goes together with an exponential increase of the GLP-1 medication penetration to the market. But there's something else happening. It's the new procedure called endoscopic sleeve gastroplasty. I'm quickly showing you a video of this procedure provided by the gastroenterologist of our hospital, who also created a kind of a pictogram illustrating in the order of his stitches. I'm just getting dizzy by looking at this picture. So let's move forward. The endoscopic sleeve gastroplasty was approved by the IFSO in 2024. The IFSO stated that it is a good procedure for WHO grade 1 and grade 2 obesity, or even for grade 3 patients who are unfit for surgery. Then some national societies, for example the French one, also published their position papers and reinforced the adoption of endoscopic sleeve gastroplasty. It's a new procedure, and there's a kind of failing data in the literature on what happens when it does not achieve the results that we expected. What do? Do we convert it to a Roux-en-Y bypass, to sleeve gastrectomy, to one anastomosis bypass? Nobody really knows. So to answer this question, I reached out to the WhatsApp group of the Young IFSO European Task Force, and I asked my colleagues to pull together a multicentric database on conversions of endoscopic sleeve gastroplasty in the time period from January 20 to June 25, with a minimum of 3 months of follow-up. We managed to gather 7 bariatric centers on board from the IFSO EC European chapter from different countries, including France, Germany, Switzerland, Italy, Austria, Turkey, and Israel, mainly from academic centers, but there are also 1 or 2 private hospitals included. So from these 7 centers, we pulled together 13 cases, so 1 to 3 cases per center. So this study basically is a patchwork of case reports. results. Patients were mainly female, 77%, mean age 43, and the median time from endoscopic sleeve gastroplasty to the surgical conversion was 1 year. The indication for conversion was always weight-related, mainly suboptimal clinical response to the endoscopic gastroplasty or recurrent weight gain after an initial good response. The conversions were 50-50 to sleeve and to bypass, and within the bypass group, again 50-50 to Roux-en-Y and to one anastomosis gastric bypass. This is the weight trajectory of the patient. So the first column shows the BMI before the endoscopic sleeve gastroplasty, which was around 38. Then this is the BMI at the time of conversion to standard bariatric procedure, and this is the BMI 90 days after. You can see that there is, in the first 3 months after conversion, a sharp decline to mean BMI from around 37 to about 33. This is reminiscent to the sharp decline of BMI observed in primary bariatric surgery. What about surgical outcomes? So all these operations were performed laparoscopically with a median operation time of 70 minutes, no conversions to open. The median postoperative stay was 2 nights and no complications until discharge, and also not even during the first postoperative year was reported. There were 2 long-term complications captured. One patient had additional recurrent weight gain and underwent distalization of the one anastomosis gastric bypass more than a year after the conversion, and another patient had a bleeding ulcer from the gastrojejunostomy after Roux-en-Y gastric bypass needing intensive care support. So these outcomes are within the quality benchmarks of primary bariatric surgery until 90 days. So bleeding rate was below 2%, there was no leak, no reoperation, no mortality, which is surprisingly good for revisional bariatric surgery. I would like to show some intraoperative images. So what we did in my hospital in Zurich, we first asked the gastroenterologist to remove all foreign material 1 week before the conversion endoscopically. We again performed an intraoperative endoscopy. And the laparoscopic finding was a bit surprising. We found something that we called a hedgehog stomach. There were still some attachments between the gastric wall and the abdominal wall, which we took down with the harmonic. And then what we tried to make sure was to find horizontal stapling area, which is between these attachments, to avoid any staple line disruption. So these were some kind of unexpected stigmata. Here we are stapling between these attachments, leading to a pouch lens, which is a bit longer than our typical pouch lens, but we did not really have the choice. At the end of the procedure, the leak test was negative. For the discussion, I would like to mention some interesting findings from the literature. So I think the physiology of the endoscopic sleeve gastroplasty and standard bariatric surgery is very different in terms of gastric emptying. You can see here on this side that the gastric emptying actually slowed down by endoscopic sleeve gastroplasty. And after standard bariatric surgery, independently of the procedure, bypass or sleeve, it is accelerated. Even after sleeve gastrectomy, the half time of gastric emptying is about 15 minutes. And the control group, the normal anatomy, is around 1.5 hours. Why is it important? Well, the postoperative neurohormonal response is proportional to the small intestine nutrient density. So maybe this is an unexploited mechanism by the endoscopic gastroplasty, and that's why maybe the conversion to bariatric surgery can achieve a very good weight loss after the conversion. So to conclude, surgical conversion of sleeve gastroplasty in our young IFSO community is quite rare. We need to reach out to all countries, and even though we found only 13 cases, indication was always related to insufficient weight loss. Surgical safety was excellent in experienced bariatric centers of reference, and the short-term weight loss was satisfactory independently of the bariatric technique of choice, conversion to one anastomosis, normal, or bypass or sleeve gastrectomy. So the final conclusion conclusion is that endoscopic sleeve gastroplasty fits in the spectrum of care. It can be complemented by medication. It can be also upgraded to a standard bariatric procedure. I would like to have the support of my team back home and invite all of you to visit us in Zurich in November for the 6th European Foregut Society meeting, which will have a dedicated session on hiatal hernia repairs in the context of bariatric surgery. Thanks a lot for your attention.
Is there any question this time from the floor? At least one, please.
What kind of platform did you use to achieve the ESG? That is to say, there is the POSE and the Apollo one. Because
yeah, I think
it's quite different.
Well, I don't have data on all of these certain cases. In our hospital, it's the Apollo system which is used.
Because I thought it was the other one. Because I've never experienced that hedgehog.
You never? Okay.
Yeah, because I happened to convert many of ESG to.
Okay.
Mainly to sleep.
Okay.
Yes.
I mean, for us, it was a complete surprise. I reached out to a lot of colleagues
spikes, you know.
before, and they told me, no, we never did it. You will discover yourself. And then when I went to Montpellier, to Thibaut Co's conference earlier this year, somebody from Lyon, I think, showed, maybe it was a colleague who's sitting here, I don't know. She showed some similar images that we found. Maybe not so massive, but I think it will come up with more collective experience.
So, Daniel, I have the feeling that, converting is not that difficult. It looks like a standard primary procedure. I mean, that it is not such a big issue.
No, technically not a big issue, but yes. It can be. I think it can be very dangerous for the patient if you staple on these adhesions, and then it will affect the nice beads of your staple line, and it might lead to a leak. That's why be very cautious. Remove all the foreign material possible by the endoscopist before, even during the operation. Take your time. Maybe allow a bit more operation time for that day. Don't overpack your program. You might wait on the gastroenterologist. Maybe in some countries, in the UK, for example, you can do yourself your gastroscopy. In Switzerland, it's not the case. You rely on another discipline, another clinic. Also, yeah, I think it's crucial not to staple on these adhesions. But apart from that, as you say, it's pretty easy.
What other measure would you recommend? I mean, doing X-rays or CT scan to see where the metallic staples are, to avoid them, see how many are in there, or just endoscopy? Because it sounds difficult to remove all the staples endoscopically.
I mean, there are no staplers in an ideal case. It is a suture material.
Kind of suture, yes. But
the suture material that you might have seen clips in my video, because I don't know for which reason, it was also a surprise for me. The endoscopist who removed this had some bleeding and marked these spots with additional metal clips.
Okay, so this
which made our job even more different.
Okay.
So it's not part of the standard endoscopic sleeve gastroplasty.
We have a question from the floor.
I just want to make a comment. There are some leads. You have to stop the suture when you're doing the procedure. So if you come around these leads, they're metallic actually.
Okay.
So it will be a great problem. Doing a sleeve also, there will be your misfire of your sleeve.
They can.
Yeah, so you have to be careful checking the back of the stomach extensively in order not to come over to these leads.
That's an interesting trick. This is what may lead to a misfiring, which may be a big problem in bariatric surgery. So if there is no other comments, we may, if you agree,
just
another one.
From the history, maybe for revisional surgery, if you expect whether you're doing a sleeve or other procedures, you need potentially another procedure. Never use metal clips. So Michel Garnier, he's performing the sleeve, and before you make a patient head is outside the surgery, he make an X-ray, he's counting the number of, and then somebody has to go in the arm and remove all the clips before he's starting to make the revisional surgery. So metal clips is a better idea. If you know, maybe potentially you need another procedure.
That's quite interesting because some surgeons put a lot of clips on the sleeve, and this may be terrible when you go for a bypass later. And that's why I was talking about, X-ray. Yeah. So anyway, if there is no other questions or comments, we may close the session. Thank you very much to all the audience. the presenters,
Thank you.
and my colleagues, and we go for the coffee break.